webinar on the theme Thrombophilia with focus on APLA and Lupus anticoagulants. It gives me great pleasure to invite our first speaker, Dr. Akash Khandelwal, Consultant and Unit Head, Hematology, Oncology and BMT, Action Cancer Hospital, New Delhi. Over to you, sir.
Yeah, hi. Thank you for the opportunity to discuss antiphospholipid antibodies and lupus anticoagulant. Thrombophilia itself is a big unit and an interesting aspect of medicine. And we'll discuss today something about antiphospholipid antibodies. How important is it is the treatment of APLA and the investigations, of course. So yeah, starting off with the antiphospholipid syndrome. The thing is the same. The name terminology has only changed. Next. So yeah, thank you. Antiphospholipid syndrome, as I said, is which is characterized by a systemic autoimmune disorder characterized by recurrent arterial thrombosis, venous thrombosis, discuss pregnancy without thrombosis. So yeah, significant proportion of the patient do in mortality or morbidity despite the treatment. Next slide, please. So yeah, so when to check for APLA or antiphospholipid syndrome? So any new unprovoked thrombosis in a young age group less than 40 years warrants an evaluation. Similarly, associated clinical manifestations, which I'll discuss in the later slides, can also trigger, can also indicate towards antiphospholipid syndrome in general as a cause. Unusual site thrombosis. So what is that? Any thrombosis in brain, splanchnic vessels, abdomen, portal vein, even upper limbs, warrants an evaluation and is a terminology used as unusual site thrombosis because it generally doesn't happen without any obvious reasons. Recurrent thrombosis, very important. Even after anticoagulant, patient has the repeat thrombosis, warrants an evaluation and re-evaluation to look for antiphospholipid syndrome as a cause. Next patient, please. Next slide. So yeah, as I said, it's a systemic autoimmune disease. So yeah, sometimes it's associated with SLE. So therefore, the terminology lupus anticoagulant is also comes from there. But it's not always the case. Sometimes 53% of the patients doesn't have lupus, but still have antiphospholipid antibodies. Similarly, can also be associated with other autoimmune conditions like rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome, and dermatomyositis. So overall, it's an autoimmune disease with or without an obvious cause. Next slide, please. So it's associated with significant morbidity, mortality. As I said, 6% of pregnancy-related morbidity, 13.5% of stroke, myocardial infarction, and deep vein thrombosis. A large number, 10 to 15%, are associated with APS as a cause. Similarly, as I said, other common manifestations could be thrombocytopenia. Yeah, that's a very important one. Any thrombosis, any patients of thrombosis with low platelets or low hemoglobin, autoimmune hemolytic anemia warrants evaluation of an autoimmune cause, including APLA and lupus, especially amongst females. Similarly, livedo-reticularis, superficial thrombophropathy, cognitive dysfunction, skin ulcers, obstetric manifestations like preeclampsia warrants evaluation of antiphospholipid antibodies and syndrome because it's closely associated with it. Next slide, please. Next. Yeah, so this is a study which was published in Blood, in which it showed that first embolic events, even in an asymptomatic carriers of high-risk antiphospholipid syndrome, is pretty high. If you look at it, the trend is 5.3% per year in a patient of asymptomatic but high risk, positive for anti-lupus, lupus anticoagulants or cardiolipin. They have a tendency of causing thrombosis at 5% per year. 5. So therefore, this warrants treatment even in an asymptomatic, or which have been found out with this because of some other previously discussed, like something and still have 3 or 2 or more factors associated with antiphospholipid antibodies, should be treated and closely followed for deep vein thrombosis. Next slide. So this is the clinical criteria. It was first defined in 92 in Japan and later in Sydney in 2006. So it includes any vascular thrombosis, 1 or more clinical episodes. This is the clinical criteria which I'm discussing first. And second could be pregnancy morbidities, 1 or more unexplained deaths or morphological fetus of 10 weeks of gestation or less, or some after 34 weeks of maybe deaths. Similarly, placental insufficiency, 3 or more unexplained spontaneous abortion of less than 10 weeks also warrants an evaluation and can be considered as a clinical criteria for APS. Similarly, lab criteria, the important one is lupus anticoagulant, the most important one present in plasma, cardiolipin antibody, IgG, IgM, anti-beta 2 microglobulins. However, having said that, these lab criteria are not itself defining as lupus or APLA and has to be repeated after 12 weeks. In order to define the criteria, 1 clinical and at least 1 laboratory criteria should be fulfilled for diagnosis of APS. However, this is an old criteria and a newer criteria has been defined for further evaluation of APS. Next slide, please. Which we'll see in the coming slide. So this is the new criteria. So yeah, this has been drafted in 2022, in which the other clinical domains have expanded. The thrombosis and the arterial thrombosis is still there. Microvascular, like suspected or established criteria. Obstetrics, which previously discussed, is the same criteria. Cardiac wall and thrombocytopenia has also been introduced as a clinical domains. Also laboratory domains, lupus anticoagulant one time or persistent, they have been graded accordingly and points are given. And accordingly, it has been defined that if there is more than 3 points in the clinical criteria and more than 3 points in the APL or the lab criteria, then it will fulfill the criteria of antiphospholipid antibodies. Next slide. So the
Sorry to interrupt you, sir. So your voice is breaking, sir.
part will be discussed by Dr. Gurleen. So I'll jump into management.
Sir, sorry to interrupt you. So your voice is breaking, sir.
Was discussing. So we have discussed the clinical manifestations, and now as the investigations will be discussed by Dr. Gurleen, and I'll discuss the management part first. So yeah, regarding the management, since it's a thrombosis, which is the most common manifestation, so anticoagulants remains the cornerstone with plus minus antiplatelets together. The DOACs, however, has shown some inferior data, which we'll discuss in the coming slides. So heparin or warfarin or other vitamin K antagonist remains the cornerstone for treatment. Next. So yeah, this is a study which was recently published in Blood, and which shows that rivaroxaban was compared head to head in a prospective study with warfarin, and in a high risk group of antiphospholipid syndrome. The events seen, that the study has to be terminated early because the events were seen which was significant in the rivaroxaban group of 19% in form of rethrombosis versus warfarin 3% event. However, the study was not long, but it was a prospective study which showed clearly that rivaroxaban was inferior to warfarin in such group of patients in a period of 1.5 years. Next slide. There was another study done with apixaban, which compared warfarin for the prevention of thrombosis in thrombotic antiphospholipid syndromes. It was also a randomized trial, but again, it showed inferior results in apixaban group as compared to warfarin. Next slide. This is the schema of this study, which I was previously discussing. In 12-month follow-up, apixaban had 318 events per 1,000 patients, and warfarin had 40 events per 1,000 person per year, which is a very significant difference. And the chances of rethrombosis in the warfarin arm was almost zero, and apixaban had a comparatively higher chances of thrombosis. Next slide. So, is DOACs almost never to be used for antiphospholipid syndrome? Not really. We can use DOACs in some cases, especially in the low risk antiphospholipid syndrome. As I said, it is not that all the patients did badly, but yeah, there is a relatively more risk of rethrombosis when treated with DOACs rather than a warfarin or a heparin. So, but you can still use it in a low risk antiphospholipid syndrome, or also in those patients who are non-compliant, not ready to monitor PTI and status, after explaining the risk benefit. Next. So yeah, now discussing pregnancy, very important aspect of antiphospholipid syndrome, even in high risk group non-thrombosis or with thrombosis patient. So vitamin K antagonists are teratogenic for in pregnancy, so has to not to be used. In that case, you can use low molecular weight heparin therapeutic dose, which is 1 mg per kg subcutaneously BD, along with low dose aspirin. It is the expected and the accepted treatment. And for those who have just high risk and there is no history of thrombosis, low molecular weight heparin in a prophylactic dose, which is 1 mg per kg subcutaneously OD once daily until 6 weeks, and with low dose aspirin until 6 weeks postpartum to be continued is recommended. Next. So coming to the other therapies, what if there are other therapies except anticoagulants which can help with non or reducing the the risk of thrombosis. One such drug which hold promise is hydroxychloroquine, a relatively cheap and good tolerated drug which has shown promise in SLE and SLE associated APLA are being used even as a prophylaxis or as a first line along with vitamin K antagonist in order to reduce the risk of rethrombosis or thrombosis in a high risk group to begin with. So there was a non-randomized study of HCQ used for the prevention of venous thromboembolism in patients of pregnancy-associated APLA suggested a significant reduction in the arterial recurrence when given alongside vitamin K antagonist. So a similar study is also being done in pregnancy. Next slide, which I'll discuss. Next slide. So this is that study which I was saying. So hydroxychloroquine to improve pregnancy outcome in women with antiphospholipid antibody, a protocol. So in which they basically were giving HCQ versus placebo in patients of high risk of antiphospholipid antibodies. The complete results of which is yet to be out, but this might show some promise and also help us in defining the safety of HCQ during pregnancy itself. Next. So other treatments, if there is other systemic manifestations, or especially with SLE or autoimmune hemolytic anemias or thrombocytopenias, can be rituximab, which can help in mitigating the B cells and also independently help with AIHA and thrombocytopenias. Even they have some shown promise in any other manifestations of SLE as well. So other is belimumab has shown some promise in again patients of SLE and especially with other systemic manifestations like pulmonary necrotizing capillaritis or even renal manifestations and skin ulcers. Next, eculizumab. I just wanted to discuss this because one aspect which we are not discussing because it's a very hard to catch entity is catastrophic antiphospholipid syndrome, which is also known as CAPS, in which there is recurrent thrombosis along with multisystemic failure. And even after giving heparin, patient tends to have repeated thrombosis and it's very deadly and has a high mortality. So eculizumab has been used off-label for them and has shown some promise. However, CAPS being a very deadly disease itself and eculizumab has a high price to it, a randomized trial is next to impossible for this. And but still off-label use of eculizumab has shown some promise in a very bad disease of catastrophic antiphospholipid syndrome. Next. So yeah, I think this we'll discuss in the end. It's just a scheme of how to go about in a patient of thrombosis, and we'll discuss in the end how you should like after diagnosis of APLA, one should do things. So over to Dr. Gurleen.
Thank you so much, sir. I would now like to invite our next speaker, Dr. Gurleen Oberoi, Senior Consultant and Lead Hematopathology, National Reference Laboratory, Dr. Lal Pathlabs. Over to you,
ma'am. Good afternoon, everyone. Thank you for giving me this topic. And thank you, Dr. Akash, for covering the clinical part comprehensively. I'm just sharing my screen. Is it visible? Am I audible?
Yes, ma'am. Your screen is also visible. Can I request you to put it into presentation mode?
Yeah, I'm just doing that. Yeah. So I'll be covering my talk under the following heads. That is introduction to thrombophilia, antiphospholipid syndrome. I'll touch upon pathogenesis briefly, diagnostic criteria, laboratory testing, and followed by the conclusion. So thrombophilia, as we know, is triggered when the equilibrium in the blood is disturbed. So we know the famous Virtue triad, which was put up by Rudolf Virtue in 1800s. He suggested that the abnormality in the stasis, the vascular injury, and the hypercoagulable state can lead to thrombophilia. So a coagulation occurring in wrong time and wrong place leads to thrombosis and thrombophilia. So thrombophilia can be genetic or acquired. There are multiple causes. It can be venous, arterial, or arterial and venous. Antiphospholipid antibody syndrome can be both arterial and venous thrombotic conditions. So it can cause both. And we have to remember that decreased antithrombotic proteins is a stronger risk factor, that is 10 to 25-fold higher chance of getting venous thromboembolism in comparison to causes which leads to increased prothrombotic protein like factor V latent prothrombin gene mutation G202210, increased level of factors. So this is weaker. However, the antithrombin deficiencies, protein C, S, and APLA are the causes of stronger risk factor for VTE. So usually when a thrombophilia presents, there's and a screening profile, thrombocoagulation screening is done, then the platelet count, PT, APTT, and TT are usually normal. And with the clinical profile in correlation, the following panel is run. So we have this panel in which we are doing 83 deficiency, protein CS, and APCR, along with that the mutation for factor V latent MTHFR and beta-2-GP1, along with that dysproteinuria and hyperhomocysteine has to be tested for a complete thrombophilia workup. However, when the APTT is prolonged, that is a guide that we have to do an APLA testing. So what is APLA? It is a clinical autoimmune syndrome characterized by venous arterial thrombosis, pregnancy morbidity, presence of, along with the presence, and I would stress upon persistence of the laboratory evidence of antiphospholipid antibody syndrome. The entities include primary APS with no prior history, secondary APS, which is associated with SLE and other autoimmune conditions, catastrophic APS, wherein catastrophically multiple organs are involved in a very short time of less than a week, and catastrophic thrombotic and thrombophilia happens in the body. Followed by seronegative APS, where the various laboratory diagnosed antibodies are missing, and hemorrhagic APS, which is also known as anti-PT syndrome, wherein the antibody against the prothrombin is there and hemorrhagic manifestations are present. So lupus anticoagulant, which is most common, is actually a misnomer in which because lupus is present in only few of the cases of the APLA syndrome and lupus anticoagulant containing patients, and anticoagulant is also a misnomer, because it in vitro causes the prolongation of APTT and all because of the of its effects on the phospholipid dependent reagents which are used in these tests. So the pathogenesis includes two hits. The first hit is disruption of the endothelium, followed by the potentiation of the thrombus formation, and there's APLA syndrome. First of all, the antibodies are produced by the B cells. These antibodies damage the endothelium and attach there, thereby activating the neutrophils, the endothelium, the platelets, leading to the production of various procoagulant factors. It inhibits various fibrinolytic pathways, thus leading to the promotion of the coagulation, and it also interferes with the trophoblast and decidual cells, leading to various pregnancy complications. Thus, it implicates various systems of the body, and causes a complete syndromic picture. So the antibodies, various antibodies are implicated, but the most common antibodies against is this antigen, that is beta-2 glycoprotein 1, and it has 5 domains. So the domain 1 of the beta-2 glycoprotein 1 is implicated in causing the thrombosis, and this is what we diagnose while using various modalities like ELISA. So ELISA against domain 1. Apart from that, there are ELISAs which target domain 4 and 5 for diagnosis as well. The beta-2 glycoprotein is usually present normally in a patient's blood in a circular form, but when it attaches the endothelium, it acquires this J form. This is usually free thiol form, which is non-immunogenic and present normally in the blood. And this oxidized, when it is oxidized, it causes the various manifestation leading to antiphospholipid syndrome. So the diagnostic criteria, as also mentioned by Dr. Akash, so the first it came in Japan by Sapporo classification criteria, which was modified by Sydney in 2006, which we know, which we have been using for a very long time. So the clinical criteria, as discussed by Dr. Akash, I'll move on to the laboratory criteria, in which the lupus anticoagulant is present in the plasma on 2 occasions. We have to remember, in the laboratory criteria, one of the most important point is various testings are done, and if they are positive, we have to repeat that to see the persistence of these antibodies in the body. So the persistence is important, and it has to be checked after 12 weeks. So every test has to be done for at 2 occasions, 12 weeks apart. And those tests include lupus anticoagulants, anticardiolipin antibody, in which IgG and IgM is seen. IgM is known to be lesser implicating. IgG is more important when it is seen to cause more thrombotic and obstructive complications. And the titers are defined as more than 40 IgG phospholipid unit, that is GPL, MPL, or more than 99th percentile of the normal population. So we have to remember that 40 GPL or MPL was used initially, but now various guidelines and recommendations have said that more than 99 percentile is the criteria we have to follow for both anticardiolipin antibody and anti-beta-2 GPI antibody. So this is the criteria which we have been using since ages, but now there have been slight modifications, and in this new criteria they have graded and they have quantified each and every presentation, and they have given an entry criteria in which one documented clinical criteria and one more than equal to one positive APL test is required. If it is not met, then the further testing is not required, is what they have said. The laboratory, I'll directly go to the laboratory part. The laboratory domains, even if it is one time positivity of lupus anticoagulant, some quantification is done, that is one. However, the persistence is what is more significant. In case of anticardiolipin antibody, beta-2 GPI, GP1 antibody positivity, IgM only is not given that much of weightage. However, the presence of IgG, moderate positivity or high positivity, is graded accordingly. So the classification of APSF more than equal to 3 points are present, then clinical criteria is met, and more than 3 points of the APL domain is met, then we can classify it as APS. So if all the 3 antibodies or tests which we just saw, that is lupus anticoagulant, beta-2 GP1 antibody, and ACL antibody, then it is definite that APLA is there, or lupus anticoagulant is positive. If either of the two tests are positive, then there is a possibility that or probability that the APLA syndrome is present. And if only one of the tests is positive, then it is uncertain. So coming on to the lab evaluation, issues to be addressed are when to test, whom to test, and what all investigations are to be performed. So coming on to the question when to test. So we have to make sure that the patient is not tested during the acute episodes, because it can lead to false positive or false negative test, as a few of the factors are acute phase reactants, and there are alteration in other factors and other levels also. So and the second point to be noted is we have to know the history of whether the patient is on anticoagulants or not. So if lupus anticoagulant testing should be done, it should be avoided if the patient is on direct thrombin inhibitors, on heparin, or on oral anticoagulants. So, if the patient is on oral anticoagulant or on DOACs, sufficient time duration should be there after the stopping of the anticoagulant for testing. However, this is not recommended, as the patient is at high risk of the various complications. So at that time, solid phase ELISA test for ACL or beta 2 glycoprotein 1 antibody can be done at any time, as they are unaffected by anticoagulants. However, one more point is, when direct NA inhibitors are there, TSVT or ECT can be used, though they are not criteria, but they can be supportive to our diagnosis. Apart from these, one more thing is I want to highlight is low molecular weight heparin is something which affects the test least, so that can be given to the patient while the testing is being planned. So the time between the coagulation and anticoagulant and the testing for DOACs, it is defined to be 48 hours, or the half-life of the drug. And for oral anticoagulant like warfarin, it is at least 7 days. So whom to screen and what tests to be performed? So as discussed, the indications are unexplained thrombosis, unusual site, neonatal thrombosis, history of recurrent losses of fetal losses, past history indicating of recurrent thrombosis, family history in the first degree relative. So according to these indications, the pre-test probability is known, and it has been advised that the patient is only tested when the probability of testing is high or moderate. However, the patient is not should not be tested in low probability testing, because undiscriminated testing can lead to a lot of false positivity and false diagnosis of APLA syndrome. So there are multiple available tests, but we should be knowing the recommended test for a proper diagnosis. The broadly classified tests are clot-based tests and solid-based assays. The lab can be tested by a variety of tests, that is DRVVT, the APTT with silica as an activator, the kaolin clotting time, where the activator is kaolin, but this kaolin cannot be used for automated assays as it sticks. It is sticky and it is opaque, so it cannot be used for automated assays. Dilute prothrombin time the mechanism is on the external pathway. The icarian clotting time, texturin clotting time, these are common pathway tests. So a common pathway test, extrinsic pathway test, or an intrinsic pathway test can be used for testing. However, the recommended tests are the two tests that is to be preferred are DRVVT, the first test, and the second test, any low phospholipid APTT dependent test like PTTLA or APTT with silica as an activator, that is silica clotting time. So at least 2 tests are to be performed. So what is the need for doing multiple tests? Because of the variability of these antibodies and the implicating antibodies for this APLA syndrome. So coming on to the pre-analytical considerations, the patient, it is very important, the pre-analytics and how the sample is collected determines how accurate your test is, as true for all the coagulation tests. So the sample should be collected in trisodium citrate by minimal trauma, and plasma is rendered poor by double centrifugation, in which it is wrong. Typo error, the platelet count should be less than 10,000. So why this is very, very important, I want to stress upon it, because double centrifugation is needed to reduce the platelet count to less than 10,000, as platelet on their membrane has phospholipids, and when freeze and thaw and various processing is done, this can be leached out and can lead to false negative assay, because the phospholipid is available for the correction of the testing. So a double centrifugation for platelet poor plasma is a must. And in this, first of all, 3600 RPM, the sample is run at 3600 RPM for a 15 minutes time, and the supernatant is collected and it is recentrifuged at 3600 RPM for again 10 to 15 minutes. So that is why it is known as double centrifugation. No ultracentrifugation or filtration techniques are needed. It may be tested immediately, but if it is not tested immediately, it should be frozen at minus 70 degrees Celsius if it is to be kept for at least 6 months, and minus 20 degrees Celsius, it is stable for 14 days. The repeated freezing and thawing should be avoided. So coming on to the LA test flow chart, the following are the international recommendations. The screening test should be done by at least 2 modalities, 2 different principles, and and they should have low phospholipid concentration, as the lupus anticoagulant is phospholipid dependent antibodies. So if the phospholipid is provided, they corrects the test. So if 2 tests are normal, the further evaluation is not needed. However, if it is abnormal, the mixing study is done, and if the mixing study is correcting, then a factor assay should be confirmed by factor deficiency should be confirmed by a factor assays, and the inhibitors are excluded. However, if the mixing study is showing a non-correction, if it is not being corrected, then a confirmatory test, which is phospholipid dependent, in which the various tests, that is DRVVT or PTTLA or APTT with low phospholipid and silica activator, in all these tests, the phospholipid is added to see the phospholipid dependence of these antibodies and the correction. So if the correction happens, it is lupus anticoagulant which is confirmed, and if it doesn't happen, then factor assays should be done and other specific inhibitors should be excluded. The PTTLA, as I mentioned, it is also one of the tests which can be done. The activator is silica. Its prolongation rules out factor deficiencies, factor inhibitors, dysfibrinogenemia, presence of hindrin. Coming on to the next one, DRVVT, which is in which the snake venom derived from Daboia roselli snake is used. In this, it activates directly the factor 10. How it is made sensitive for APLA syndrome is by diluting it. So dilution of venom and phospholipid makes it particularly sensitive for detecting the lupus anticoagulant. To add specificity, it is always paired with the confirmatory test, as mentioned before. The currently used neutralizing agent is inosithin, and the reference range for DRVVT is 35 to 40 seconds. These tests are interpreted as normalized ratio. I want to stress upon this as well. Normalized ratio, why it is important? Because it kind of homogenizes your assay and decreases the variations between inter-instrument, inter-method, inter-technician difference in the and inter-lab variations. So the screen ratio, how the normalization is done by normal pooled plasma. The screen ratio is determined in which the screen clotting time of the patient plasma is divided by the normal pooled plasma. The mixed ratio, wherein the after mixing, the clotting of the patient plasma is divided by the normal pooled plasma again. The confirmed ratio is determined the same way, and the finally the normalized ratio is calculated, which is screen ratio by confirmed ratio. And how it is interpreted? The DRVVT, as I told, the reference range is 35 to 42nd. However, the reference ratio range is 0.9 to 1.04. So, if it is more than 1.05, it is suggested that lupus anticoagulant is done, and further confirmation and further testing should be taken. But it excludes the factor deficiency and inhibitors. The prolongation of the DRVVT, which corrects with normal plasma, is because of the clotting factor deficiency, but it can also be because of a weak LA. So weak LA can also be corrected by these normal plasma when a 1:1 mixing is done. But if it is to be excluded, 1:4 mixing is to be tried and to minimize it. The prolonged TRVVT, which corrects with phospholipid, are confirmed to be lupus anticoagulant. Similarly, if screen time is normal, the further testing is not required, and this I already discussed. So coming on to the ELISA testing for anti-cardiolipin antibody, we have to understand that even the cardiolipin antibody is actually beta-2-glycoprotein 1 dependent antibody. Then only it is known to be specific for antiphospholipid antibody syndrome. However, if it is a direct cardiolipin antibody testing by ELISA, it is not specific for APLA. So an ELISA test wherein the antigen on the microtiter plate, which is coated, is a complex of cardiolipin with beta-2-glycoprotein 1, either domain 1 or domain 4 or 5, is specific for the APLA syndrome. So this I already discussed. The cutoff value of more than 99th percentile is more accurate for this, and repeat is recommended. Same for anti-beta-2 GPI antibody. The domain 4, 5, and 1 are the targets for which the testing is done. The triple positivity is more clinically more sensitive than double or single, as discussed before. These are the 3 guidelines which we have been following. The first to come was in 2009, followed by in 2012, and then CLSI. So in all these guidelines, most of these recommendations are similar. However, the testing order is different in CLSI, in which the screen is followed by confirm, followed by mix. The cutoff values are different in 2012 guideline, that is 97.5 percentile, and for CLSI as well. Rest all of the recommendations are more or less same. So the progress in the new phospholipid antibody assays which are being developed, this is the new development which is happening because of the DOAC being used and all. So DOAC stop assay is being developed for testing of the lupus anticoagulant on the patients which are already on DOACs. Another antibody, which is a very important antibody, that is antiphosphatidylserine and prothrombin. It is being stressed upon that this is a very important antibody, and if it comes out to be positive with a triple positive test of APLA, then it is known as tetra positive, and it is more sensitive and more predictive for predicting any obstetric or thrombotic complications. Other studies, even complementopathies are being studied. So I'll conclude my talk by saying that the combination of at least one clinical and one laboratory criteria is required. The testing should be limited to the patient who have a significant probability. It shouldn't be done indiscriminately, because it can lead to a lot of false positivity. Persistent positivity of laboratory test is important because transient antibody are well known. The triple positivity correlates more strongly with both thrombosis and pregnancy morbidity. Here I would also press that the testing which is preferred is for lupus anticoagulant testing. It is DRVVT along with a low phospholipid APTT with silica activated, that is a silica clotting time, and along with that IgG antibody for beta-2 glycoprotein 1 and ACL. Origin of antibodies and unpredictable behavior in APLA is still an enigma and needs further research. So with this, I'll conclude and I'm open for all the questions. Thank you for the patient listening. Any questions?
Ma'am, we had displayed the questions on the screen, ma'am. If sir and you can take the same.
Dr. Akash?
Yeah. So, so which heparin options are the most convenient? So, for me, and in general, fondaparinux or a low molecular weight heparin, both are equally convenient. For fondaparinux, you can have a daily dosing as well. Even low molecular weight heparin is not challenging. You can take it twice daily. So yeah, these two are the best options. So rituximab has a relatively higher risk of infections, but these are all manageable infections. So the risk benefit ratio in such cases always favoring rituximab. Should not be afraid of like infections, because these are easily treatable infections and transient in nature. Yes, actually, ITP is actually a prothrombotic state. So even if there is an idiopathic cause, there is no obvious cause, there is a still higher risk as compared to a normal population for the risk of thrombosis. So yeah, this is how it is. Because of the antibodies, there is a risk of thrombosis always higher as compared to a normal population. Any other questions we can discuss?
Any questions
So
from lab side? Dr. Akash, you were saying something.
Yeah. So I was just trying to highlight that the conclusion of the talk I didn't discuss. It was that every thrombosis has to be treated by an anticoagulant, but especially with APLA, one has to even consider antiplatelets as in combination if the APLA is defined. And also, as you have rightly mentioned, that the lab criteria has to be checked after 12 weeks again. So, but that is basically after 3 months. So, accordingly, then
So
I have to.
along with that, I would also press on the fact that laboratory criteria are never interpreted in individuality. So it has to be always in the clinical setup. You have to interpret the laboratory criteria.
Absolutely.
In
Absolutely.
isolation,
That is the truth. Yeah. So yeah, so any transient positive lupus anticoagulant has to be repeated, and if it's not there, then it is not lupus. It could be because of n number of reasons as well. There could be cross reactivity.
the
Some say
infections,
transient
the
lupus, but
trauma, yeah,
still
multiple
requires follow-up.
non-specific features. Yes.
Good. Yes. So these are the things. DOACs have shown some inferior results over the trial but it's not that people are not using it. It is being still used, but you have to be very careful while using, especially amongst high age group. If there is a second thrombosis, do not use DOAC. Please do not use DOAC because it has failed and there is this risk of repeat thrombosis even after on the novel anticoagulant. So yeah, that's that.
Yeah, one of the question is, can we start empirically anticoagulant in recurrent abortion even if all tests are normal? I think no, never. What do you say, Dr. Akash?
So yeah, even if the reports are negative, there is the strong practice to use at least ecosprin somehow or the other. Even when in AIMS it was used to be like that. So yeah, ecosprin is very harmless kind of a drug. You can at least use ecosprin.
Aspirin, yeah. So
And
antiplatelet maybe, huh? Yes,
yeah,
you're
and
right.
follow up accordingly. If there is still you're feeling IUGR, you can still use even heparin. It has been used by obstetricians, and I don't see any harm unless there is some bleeding involved or there's low platelets that you can't use it on the risk benefit ratio. Low molecular weight heparin. There's no other option. Others are not being tested either, or vitamin K antagonist like warfarin is teratogenic. And it is teratogenic. It has been documented very clearly that you cannot use warfarin acetrom in pregnancy or planning before pregnancy because it causes teratogenic effects, by which I mean there could be dysfunctional limbs or even face dysmorphology. So one has to be very careful. So as per the lab side, beta 2 microglobulin has also to be repeated, or it's just for the lupus anticoagulant that has to be
No, it
repeated?
has to be. It has to be
All
repeated. Actually,
three.
the repetition is for all the three antibodies, because the
Okay.
antibody transience is not limited to lupus anticoagulant. It can be transient anti-beta to GP1 or anti-ACL also. And anti-ACL is much more common in cases in non-specific cases, because infection and RA factor and all that those things leads to a lot of false positivity. So anti-ACL, anti-beta to GP1 both needs to be repeated too, along with that lac.
All right. All right. A lot of times this is the question because thoda sa costly ho jata hai test. So like, okay, you
Yeah.
repeat this only, then we'll see. So that is why I was asking that is it absolutely necessary to repeat it, or we can just repeat the lupus anticoagulant?
Yeah,
Because lupus
actually,
anticoagulant, of my understanding, is the most specific one or the most deadly one. If it's positive, it has to not to be ignored one. It's the most important one.
so even lupus anticoagulant, when you go into the depth of the pathogenesis, it actually uh, is associated with activity towards beta to GP1 as well as prothrombin. So they are two. These two it mostly affects. And you are rightly saying lupus anticoagulant is most significant and is more correlated with the complications. However, uh, even anti-ACL and the triple positivity, as we know, is known to be much more correlated with both obstetric and thrombotic complications that way.
All right. There's another question. So the dose is 1 mg per kg for prophylaxis once daily, for therapeutic 1 mg per kg subcutaneously twice a day, 12 hourly. So Clexine has to be given subcutaneously. It is not formulated for IV access. Can be used, but yes, still used subcutaneously and should be used like that. And the dose is 1 mg per kg. So you have to know the weight of the patient and give accordingly. If she's 80 kgs, give 80 mg. If she's 60, give 60. If she's 40, then you can give 40 as well. And also there is another option of giving 120 mg subcutaneous, 120 mg per kg, or 120 mg as a flat dose for single day. I hardly use that, but that's also an option. I prefer 1 mg per kg subcutaneously twice daily for treatment and once daily for prophylaxis. I see another question. For how many days before oral rivaroxaban tablets shall be discontinued before testing lupus or thromboprophylia?
The recommendation, yeah,
Yeah, that's for you, I think.
you can also answer, but the recommendation is around for all the DOACs, the common recommendation is 48 hours. However, the half-life has to be considered while discontinuing and planning the testing of these and lupus antibodies.
Yeah, I suppose 48 to 72 hours is fine for all.
Yeah.
For all
The
DOACs.
common which is given in the guidelines is 48, but then also one has to keep in mind the half-life. So, any other questions? This
So
is for
this
you.
question is lactation also Rivarox contraindication. So DOACs have not been tested. So DOACs have not tested in lactation because there is some concerns regarding transfer of it to the babies and causing bleeding. So yeah, better use low molecular weight heparin.
I think there are no further questions. Sophia and Himanshi, are they?
Ma'am, we have 2 more questions.
Okay. In young stroke patient, do you ask? Yes. So young stroke patient is actually a high, it comes into high probability criteria. So APLA testing is to be done in young stroke patient. It has to be done. So as I mentioned, we define the testing, or we decide the testing in the patient on the basis of the pre-test probability criteria. So they have defined clearly that the high probability criteria are there, they are moderate, they are low, as we discussed. So this comes under the high probability. So it has to be tested. Dr. Akash.
Yeah, absolutely. Any young thrombosis, any place, especially unusual site, has to be tested.
As
Yeah, there's another question. Warfarin in lactation can be used if there is any skin problems or any bleeding. Stop it. Can be used. No other effects are be noted in a baby when post in a lactating mother on warfarin.
So we don't have any more questions.
All right, it was a great session. I think we were able to answer all the questions and were able to meet the agenda and share our practice.
Yeah, Dr. Akash, it was a pleasure, and it was an insightful discussion from your end as well. And I would like to thank Himanshi and Sophia for very well organizing it in a very well manner, and Sujit and Sankalp for bringing this up and taking it forward. So, a very well organized and a very relevant topic, I would say. Thank you, everyone, and thank you, Dr. Akash.
Thank you, Dr. Gurleen. Thank you, the organizers. Done very well. So, planning and seeing further collaboration soon. All right. Bye bye. Thank you.
Okay, bye bye. Take care. Bye.